stress this is an educational seminar, so we'll certainly go over this field of regenerative medicine and try and give you as much of information that we can. But yeah, understand that we'll leave plenty of time at the end so that we address all of your questions, and so that what you take away from tonight is what you wanted to take away from it. So just let's see here. Just as an introduction, again, I'm Dr. Joel Richneck, and I've been a practicing physiatrist here in Grass Valley for 17 years now. I'm a managing partner in our clinic here in Grass Valley, along with my partner, Dr. Mike Jensen. I'm board certified in both physiatry as well as sports medicine. I've been a Regenexx affiliate now for 5 years. But to be fair, I've been practicing various forms of regenerative medicine since my years in residency some 20 years ago. And then just some further background. I myself have a very active lifestyle. I enjoy movement in various forms in the outdoors, especially in the mountains of our home here in the Sierra Nevada. And I think this background gives me a unique perspective in terms of how I treat patients, in that I know the importance of movement, and having gone through my own injuries and setbacks, I understand what it's like to be taken away from these movements and opportunities. And this background really has shaped our treatment philosophy here at Mountain View Rehab, which, in a sentence, what we really strive for here in the clinic is getting people back to doing what it is that they're passionate about, various movements and activities that they are passionate about. So this background really has shaped that philosophy. Why you're here? Well, many of you are here because you're going through your own journey of injury, and from that injury, suffering pain, and certainly downtime, trying to recover and heal from the injury itself. You may be looking for alternatives to surgery because it's gotten to the point where you've seen a surgeon, but you're not quite ready for surgery. Or you've been told by a surgeon that you're not a candidate for surgery. You're looking for options. You want to get off the medications that you've been on forever. And most importantly, again, you want to return to the activities that maybe you're not able to do right now because of the injury. Tonight, we'll discuss a few things. We'll spend a brief amount of time talking about current options in orthopedic care. Then we'll jump into both fields of regenerative medicine as well as interventional orthopedics. And I'll explain what both of those are in a moment. We'll also discuss and talk a little about what this organization of Regenexx is, and why they are so much different than any other clinic offering this technology out there. And we'll spend some time talking about some misinformation about various other stem cell products out there. And then we'll wrap it up by addressing the questions. So, current options in orthopedic care. Many of you have gone through your own journey and are very familiar with, many of us start with medications after we're injured, and that doesn't quite address the issue. Then we jump into conservative treatment, and if that fails, many of us are sent to a surgeon as the last step. So again, we've all been through our own journeys, and oftentimes we'll start with just taking over-the-counter medications, whether it be Tylenol or ibuprofen, and if that doesn't quite address the issue, many of us receive prescriptions and get prescription strength medications from our family physicians. And in some cases, we get lucky, and this may address the pain enough to allow us to heal from the injury and help us get back to these activities. But more oftentimes than not, we're finding these are temporary band-aids at best. And of course, there's numerous side effects that can occur from medications. So the next step in that journey oftentimes leads to conservative treatment. And there's a variety of options here, ranging from physical therapy to chiropractic treatment, acupuncture, or even massage therapy. Um, and to be honest, I mean, the vast majority of people will respond to conservative care. I tell everybody who walks through my clinic that there's two goals to treatment. First and foremost is to address that pain issue. And once addressed, the critical next step is being trained in the rehab process, because what that does is oftentimes address mechanical deficits that may have led to the injury in the first place, and therefore really is instrumental in terms of avoiding that injury from returning. If we're having difficulty addressing the pain issues as that first step, then oftentimes we'll resort to injections, whether it be steroids or many of you are familiar with hyaluronic acid, which is the lubrication injections we oftentimes use for knees. And again, sometimes we're lucky in the sense that this will address the pain enough to allow us to progress in the rehab process. But again, we're finding that many times we only get temporary response, even just from the injections. And of course, we're all learning that steroids have their own negative impact. And so the next step in that classic journey of treatment is, if all else fails, oftentimes we're sent to go see one of our surgical colleagues who may offer joint replacements, tissue removal, or even tissue repair. Interesting about surgery is that over the course of the last 5 to 10 years, there's been more research regarding the outcomes of surgery than there has been probably in the previous 100 years combined. And although there's plenty of things that surgery is very successful for, we're finding that many of these outcomes, many of these surgeries are truly ineffective. And of course, we all know that there's various risks to surgeries. Doesn't always work. And of course, once done, can't be undone. Now, jumping into the research a little further, again, the data tells us that 47% of the time, surgery can be medically reasonable and necessary, and oftentimes successful in that scenario. But that tells us that 53% of the time, we're finding that surgery is ineffective or maybe even inappropriate. So the research is telling us that there's problems with the surgical model. It's not the end all. And therein lies where we transition into this world of regenerative medicine. Now, at its essence, what regenerative medicine is basically taking our own cells, namely platelets and stem cells, which are very, very powerful healing cells, and using them to treat injured tissue, whether it be tendons or ligaments, meniscus or labrums, or even nerve issues. Or in the case of degenerative issues, helping alleviate these symptoms that can come from symptoms such as, or issues such as arthritis. What can be treated? In our clinic, we're treating all orthopedic issues, knees, shoulders, hips. We're treating spine, elbows, hands and thumbs, as well as foot and ankles. We're treating all various tissues regarding all those joints, whether it be tendons, ligaments, the joints themselves, or again, nerves or labrums, what have you. What is interventional orthopedics? Well, interventional orthopedics is essentially what makes regenerative medicine successful. And in a nutshell, what it is using image guidance or technology to help guide and deliver these cells specifically to the injured tissue itself. And again, we're finding through this field, we're finding that this is really instrumental in terms of making regenerative medicine work. The correlate to interventional orthopedics is interventional cardiology. Now, most of you likely remember that at one time, probably over 30 or 40 years ago, anybody who had a heart procedure went to go see a cardiothoracic surgeon, where surgery involved opening up the chest to access the heart to offer treatment. Interventional cardiologists discovered a way using technology to take a catheter, insert it into a vein in the leg, and guide that catheter to the heart, where treatment is applied, whether it be implementing a stent or removing tissue. So it's a minimally invasive procedure done using technology and image guidance. And essentially what this has done is, anybody who gets heart procedures now 70 to 80% of the times is done using interventional cardiology. So essentially it's taken over 70 to 80% of what cardiothoracic surgery used to do. Interventional orthopedics is the same concept. We're using technology, image guidance in the name of x-rays or ultrasound imaging to help guide our needles to place the cells very specifically in the site of injury. And many of the leading minds in this field of interventional orthopedics and regenerative medicine feel that this will follow the same direction that interventional cardiology followed, and that is, in the next 5 to 10 years, this will likely take over 70% of what's done surgical now. So very, very powerful technology. Diving in a little bit further, in the world of orthopedics, we have various procedures that we're able to implement, ranging from simple injections to surgery. Most people in this field provide simple injections, and what that means is what they're doing is they're injecting a medication, namely cortisone or steroid, into the area of an injury of the joint itself. So many times they're not even providing a diagnosis, specifying a specific tissue contributing to the injury, and they're certainly not trying to deliver that medication directly to the tissue. With the advent of technology, more and more people are using ultrasound imaging to help guide that to some degree. But again, they're just getting a little closer to the tissue itself. It's not a direct delivery. That's in contrast to interventional orthopedics, who first and foremost, the interventionalist is going to identify very specifically the tissue that is contributing to the issue, to the injury itself. And in the example of the hip, understand that there's many tissues in that joint that can be contributing to the pain, or it could be a number of tissues. There's tendons, there's ligaments, there's the joint itself, there's the labrum, or sometimes it's even the bone. So the interventional orthopedist is going to identify specifically that tissue or tissues, and then use the guidance to help deliver those cells specifically to that tissue. Likewise, for the knee, as well as the shoulder, understand that, again, there's various targets, there's various tissues that could be contributing to the injury or tissues. So that is the world of interventional orthopedics. What do we inject? Well, another name for these cells is orthobiologics. And under that umbrella term, we have concentrated platelets, we have platelet lysate, which is a platelet product, and we have stem cells. Platelets are simply cells that we get from a blood draw. Once the blood is drawn, the blood goes to the lab where it's processed and concentrated into a very concentrated platelet solution. And within the platelet, there are various growth factors and cytokines that are very powerful healing tools, very powerful healing tools that can, again, restore tissue health. And we're using this in the case of mild to moderate arthritis, as well as tendon and ligament tears. Platelet lysate, as I mentioned, is a platelet product. And essentially what we're doing with platelet lysate is taking a platelet and lysing that membrane. And what that does is it provides immediate release of those same growth factors and cytokines. And we're finding that this is a lot less inflammatory than platelets. And therefore is particularly effective at addressing nerve issues. So oftentimes we're using this in the case of nerve injuries such as a radiculopathy or pinched nerve from the spine, or we're using it in the case of entrapment injuries such as carpal tunnel. Then there's a stem cell product, and we get stem cells from bone marrow. And once the bone marrow is aspirated, the marrow goes to the lab where it's processed into a very concentrated stem cell solution. And stem cells are in essence like the general contractors. And what they do is they coordinate all these various players that are involved in the healing process and get them to the site of injury. And from there, start the repair process. Again, we get these from a bone marrow aspirate. very powerful healing tools. And we're using stem cells because it's a bit more powerful than the platelets. So we're using them in the case of more moderate to severe arthritis or for more severe tears affecting tendons and ligaments. Our procedure breakdown, 80% of what we do are platelets, 20% of what we do is stem cell. And this is significant. Many people believe that the only thing out there that's available are stem cell. The fact of the matter is the platelet is more than powerful enough to address 80% of the issues out there. Not everybody needs stem cells. And this is significant simply because the platelet procedure is a lot less involved, and consequently, the cost is significantly less. What is REGENXBIO? Moving on to this company of REGENXBIO, which I've been an affiliate now for 5 years. And REGENXBIO truly is the pioneer in terms of both regenerative medicine and interventional orthopedics. They've devised many of the techniques that we're using in the interventional orthopedic world to deliver these cells. And they've done a lot of research that have evolved the world of biologics to make them as good as they can be. So the combination of the two has proven to be a very advanced regenerative medicine option. Now, there are many ways that REGENXBIO is vastly different than the vast majority of other clinics offering this procedure. And before I became affiliate 5 years ago, I did a lot of research on various other companies and various other ways to offer this. And through that process, I discovered how REGENXBIO was different. And there are specific differences that really struck me that I'll discuss a little bit later. But many of the ways that they're different, first and foremost, it's experience. They've been doing this longer than anybody. Their devotion to research in all forms, whether it be clinic or lab research. In many cases, they're the only ones that are doing this research. Their platform is far different. Anybody who's performing REGENXBIO procedures is using image guidance. They're different from the standpoint that only orthopedic specialists do procedures, their REGENXBIO procedure. Our cell sources are different. Our harvesting techniques are different, as is our dosing. Now, jumping a little bit further, REGENXBIO has been doing this work since 2005. Again, not only have they been doing this longer, but they have invented many of the techniques that we're using today. And ultimately, at the end of the day, experience leads to better outcomes. Our platform is far different than any other clinic. Most clinics are offering a simple bedside centrifuge processing process. And so what that means is once the cells have been withdrawn either from a blood draw or bone marrow, they go into a centrifuge, buttons hit, and out the other end comes the same product for everybody. So essentially you're taking, there's no customization process whatsoever. Our platform, not only do we have a centrifuge, but we also have a hood and all the various tools that allow us to process this and manipulate it such that we can customize the outcome to this. So not everybody gets the same medicine, essentially. Everything is customized. And this also allows us to concentrate this greater than any other processor out there. So again, ultimately, this leads to better outcomes. Our cell source in regards to stem cell, we use only bone marrow. Bone marrow, we use bone marrow simply because it has been by far the most researched. It has been proven safe, and it has been proven more effective than any other source out there. So again, this ultimately comes down to better outcomes, which is why we use the bone marrow source. Our harvesting techniques are such that we are able to get far more stem cells than any other person at other clinic out there because of our techniques. And this is important in large part because we have discovered that the more cells we can get, the better outcome we're going to have. So that's first and foremost, but oftentimes we'll see folks who want to get more than one joint addressed. And again, we can only verify whether or not we can treat that joint based on how many cells we have. So the more cells we can get, really is it would be more successful for the specific joint, but it can allow us to do more than one joint. We're able to measure our cells. So after the processing process, we have ways of counting those cells. And that's something that no other clinic out there is offering. And ultimately, we have discovered that we need at least 400 million cells to be successful in a joint. And so, again, to verify prognosis and to verify exactly what we're delivering, we're able to provide this information. I've discussed the importance of image guidance. Again, this truly is what makes regenerative medicine successful. Without guidance, this technology just simply does not work. Now, jumping into the research avenue of things, I mentioned earlier that there are certain parts of the REGENXBIO that really made my decision in terms of becoming an affiliate. And the main one really was research. I mean, understand that this field is still very young. We are still learning a lot. We have a lot to learn. We've learned a lot, but we still have a lot to learn. What we're offering now is better than it was 5 to 10 years ago. More than likely, what we'll offer in 5 to 10 years will be better now. And what that comes down to, in order to evolve in that direction, we need the research. And so anybody who's receiving a procedure from a REGENXBIO affiliate joins our registry. And what that means is that individual is followed after the procedure to assess for outcome. And this is partly how we get our information, how we can prove or disprove success. And so through this process, we have the world's largest data bank in regards to information. And this has fed various other research. And in fact, the literature that's been put out has been put out there. 44% of it has been supplied by REGENXBIO. So this data registry feeds into our clinical research. Again, 44% of the papers put out there has been done by REGENXBIO. So, again, in order to evolve this field, the clinical research is critical. Likewise is the lab research. Again, we're constantly tweaking the system to make it better because we're constantly learning things. We're constantly finding ways to make this technology work better. And again, ultimately, this at the end of the day, this will lead to better outcomes, better success ratios. Anybody who is under the REGENXBIO umbrella, is a REGENXBIO affiliate, orthopedic medicine is what we do. This is our passion. This is our specialty. This is in contrast to other clinics who, there are many clinics who may be trained in dermatology, yet they're offering this technology in dermatology, but orthopedics, so they're not specialists. Other times, clinics will be, or procedure will be done by nurse practitioners or PAs. Again, they're not specialists. Anybody as a REGENXBIO affiliate, this is our passion. This is what we do. This is what we know. So a typical procedural flow in the case of platelet-rich plasma, it all starts with an initial evaluation where we spend an hour evaluating and examining that individual. And from there, we get the information. We verify diagnosis and verify whether or not you'd be a candidate for this procedure, as well as what your prognosis, what to expect as an outcome from the procedure. And if the individual moves forward, then they're scheduled for a blood draw. And once the blood draw is complete, it takes about an hour or two to process the blood. So they come back an hour or two later for the re-injection. And then quite frequently, we advise the rehab process afterwards because, again, there's oftentimes much work that still needs to be done in the rehab process once the pain's been addressed. Again, it's critical that the biomechanics be corrected, and only the rehab process can do that. And then we schedule a follow-up appointment 2 months later just to see how things are going at that point. In regards to the stem cell, again, it starts with initial evaluation. And then if one moves forward, the stem cell is a little bit more involved. We got 3 different procedures that take place over the course of 5 days. It starts with a pre-injection or prolotherapy injection. And what that does is it prepares the joint for the stem cell that we do 2 days later. And on the stem cell day, that starts with bone marrow aspiration. Once aspirated, it takes about 3 or 4 hours to process the bone marrow. So the individual comes in the morning for the aspiration and usually comes back earlier in the afternoon for the re-injection. At that time, they're injected with both the stem cell and the platelet. And then 2 days later, we put more platelets in there, from which we get from a blood draw. And, platelets really are critical to the stem cell. Essentially what they do is they fertilize the seed. So we're finding that the stem cell is much more powerful when platelet is added to it. And again, that's followed up with rehab and then a follow-up in 2 months. Now, jumping into this world of stem cell hype, many of you have encountered various hype regarding this technology. And again, there is a lot of hype out there because there is a lot of excitement regarding this very new technology. The biggest culprits that we're seeing out there is the amniotic world. These clinics that are calling the amniotic or placental or cord blood product a stem cell. And that's placed in quotation simply because the research doesn't pan this out. This product is not a live stem cell. In fact, it's a dead tissue product. And this has been verified not only by the research done in our lab, but has been done, this research has also been done by a dozen reputable universities around the country. And again, all are coming up with the same conclusion that it's a dead tissue product. The FDA has also recognized this as a dead tissue product. And in fact, anybody who's calling it a live stem cell procedure, the FDA is cracking down on these clinics and closing them, and oftentimes giving them a rather significant fine. Now, it's not to say that these products don't have regenerative potential. They do carry growth factors, much like platelets do. But the fact of the matter is that the amount of growth factor that's in these products is a fraction of what platelets are. So the potency of platelets, again, is far greater than the amniotic product. Yet the amniotic product is oftentimes 4 or 5 times the cost of platelets. Many times these procedures are done in a chiropractic office, done without guidance, typically. Oftentimes they're done by a non-specialist, namely a physician's assistant or nurse practitioner. Again, these are clinics that are offering dead cell products. And again, they oftentimes are quite a bit more expensive than platelets. One of their biggest marketing catches is that the individual stem cell is just simply too old. You need the younger product. I can't tell you a number of times I've had patients come in and they've been fed this line. Very, very common. The fact of the matter is our research proves that this is not true. Our research suggests that there's no correlate between age and outcome. We've done plenty of people in their 90s and they still do very, very well. So, again, don't believe the hype that this marketing is feeding. Now, as you do your research regarding this technology, regarding clinics that are offering this technology, let me just list a few red flags to be cautious for. Any clinic who's offering heavy discounting or heavy emphasis on financing, this could be potentially a red flag. Furthermore, there are many clinics out there who are, advertising this technology as a cure-all, meaning that this is going to address the rash on your skin or whatever neurological problem you may have, in addition to your orthopedic issues. Anybody who's pretending that they can treat everything, that's very likely to be a huge red flag. Anybody who suggests that anybody is a candidate, again, a red flag. When we evaluate folks, we tell them forthright, whether or not they're a candidate or not. And if they are a candidate, whether they're a good candidate, a poor candidate, or somewhere in between. Again, not everybody is a candidate for this technology. And of course, any clinic who's offering amniotic or cord blood and calling it a stem cell procedure, huge red flag is that is fraud. And then there are other clinics who are offering fat. This right now is illegal. The FDA doesn't recognize this as a viable treatment option. So again, be cautious for that too. And then further, as you're doing your research, I invite you to copy down this website, stemcellreview.com. This is a very unbiased source, and they grade all these various clinics who are offering this technology on various aspects as to whether or not they do research or using image guidance, what have you. And again, a nice unbiased source. Again, I think you might find that helpful as you do your research. So, I mean, that was a brief introduction on this world of regenerative medicine. In summary, we have found that this technology has proven to be very powerful in terms of getting people back to doing the things that they're passionate about without surgery. Truly, it's a combination of regenerative medicine with interventional orthopedics that makes this successful. Regenexx has been doing this longer, and really their process is much more sophisticated than anybody else. They truly are the leaders in this field. And then finally, be cautious of the magic stem cell approach. So before, again, we want to spend as much time as you all want on questions to further, address whatever questions you may have. But I invite you to take down this information, our phone number, as well as our website. And certainly if you have any other questions that weren't answered tonight, please give us a call or send us a line via email. Or if you want to see if you might be a candidate for this technology, please give us a call, and we can try and set you up. So that's the educational seminar part of the webinar. What we'll do next is jump into Q&A.
Hi, yeah, I wrote a question. It sounds wonderful. I wonder if you take Medicare.
We do take Medicare. We take most insurances, actually.
Awesome. That's great.
No. For the evaluation, yes.
I'm sorry. Yes.
Medicare does not cover the procedures at this point.
So do you have some place where there's a general idea of how much it costs?
Yeah, I can tell you exactly. If you were a candidate for a platelet procedure, let's just say, we're treating Dr. Richneck is treating your knee. A platelet procedure would be $1,300 for one joint. Sometimes people have two joints done at the same time. The incremental cost is very nominal, only $250. So two joint platelet procedure would be $1,550. If it's a stem cell procedure, then we're looking at $6,300. And if it's a bilateral stem cell procedure, meaning some people do both knees, then it would be $6,950. And does that answer your question?
Yeah. Can I just ask one more quick one? With carpal tunnel, do you use the platelet or the lysate?
So for carpal tunnel, we'll use the platelet lysate. And again, we're finding that tends to be a lot more effective at issues in large part because platelets themselves can be a little inflammatory initially. And we're finding that the nerves don't like that so much. So the platelet lysate has been very effective for us, yes.
Okay, well, let me ask one more question. Sorry to take up too much of your time, but so I had been diagnosed with carpal tunnel and arthritis, and one orthopedist said he didn't know if having the traditional carpal tunnel, if having that operation would make a difference because of the arthritis. Have you run into that with doing the lysate?
Well, so, I mean, oftentimes there's been a number of cases where we treated both the carpal tunnel and the arthritis. And, again, for the carpal tunnel, we're treated with the lysate, but then we would use more of a concentrated platelet solution treating the arthritis.
Oh, great. Okay.
Yeah. And that would be considered just one procedure if it's on the same side.
Mm-hmm. Okay, good. Well, thank you. I'm going to make an appointment.
Okay, well, thank you. All right, take care.
Thank you.
She's already an existing patient. No,
All right.
no, that was Elizabeth Johnson.
Kirsten, can you hear me now? So, sorry, Kirsten. Maybe if you can write that and just send it to us, we can address it that way. Renette, can you hear me? Hello?
I'm here. Can you hear me?
Yes, I can hear you.
Yeah, the question that I have is I am a heart patient, and I noticed that on some of the literature I copied that several of the medications I'm on I'd have to be weaned off and get onto something else. And I was wondering, do you work directly with the cardiologist, or is that something I would do, and how effective have you been with heart patients that have these procedures?
Well, so what we do is on initial evaluation, we'll go over the very specific medications that could be problematic. We give you literature describing what the medication is and why it may be problematic, with the idea that you go back and maybe talk with your cardiologist to see if that's something that, oftentimes what we'll do is we'll give you other ideas of medications that you can substitute to. And again, if the cardiologist gives you their blessing, then they make that change ahead of time. The only medications that we suggest stopping are medications like statin medications, or if there's a blood thinner, depending on which blood thinner it is, we suggest stopping it a couple of days before the procedure, but starting it right at the night of the procedure, which is, many people have gone through that process doing other procedures.
Right. And there's a beta blocker also that I think I saw in there.
Mhm.
Statin, a beta blocker in the blood. So I'd have to work obviously in conjunction with the cardiologist.
Yeah, and just see if they're comfortable making those changes, and if they're comfortable, great. And again, these are just these are recommendations, because I would say that the science isn't it's not like a make or break situation. It's just simply, if you can make the changes, it will help increase prognosis. It's not going to make or break it necessarily.
I see.
So if you stuck on it, doesn't mean that you'd be a definite failure, is what I'm trying to say.
Okay. All right. Great. Thank you.
You're so welcome.
Mhm.
Take care.
You too.
Okay. Robert, can you hear me? Let's see. Robert, can you hear me?
Okay, can you hear me now?
Oh, there you are. Fantastic. Yes. How are you?
Okay, I'm doing well. I want to talk to people that, I am a physician, and I had like a meniscectomy, like a cartilage removal on the right knee in 2003. And I did well for about 5-10 years, and then it started to have pain and swelling. And you treated me with stem cell therapy 3 years ago. And I have to say that I'm feeling about 90% better, or even more. So it doesn't prevent me now from doing anything that I was doing before. But I do have a few questions, basically.
Yeah.
Since you started treatment 5 years ago, did your approach to treatments different with experience and then knowledge and evaluations from the research?
Nothing has been implemented yet, although we are looking at there's been some new research that suggests that, for knee arthritis specifically, that sometimes it helps to treat the bone as well as the joint. That hasn't been implemented yet, but it is something that might. But apart from that, there really has been no other changes.
Okay. Another question is that I do have Dupuytren's disease. Is it effective on Dupuytren's disease?
No. Unfortunately not. I mean, it's just the tendon's too scarred down for it to really be able to offer much, lengthening of that, unfortunately.
Okay. And I do have an answer for the lady who has heart disease because I had before the procedure, I had 2 heart attacks, 5 bypasses, 4 stents, and there was no problem at all with the procedure. So I want to reassure her.
Oh, well, thank you, Dr. Goslin. Thank you for that support, and glad you're doing well.
I'm doing really, really well. Thank you so
All right,
much.
I haven't seen you on the trail lately.
Yeah, okay. And how many people are listening to this presentation right now? Do you know that?
So I think initially we had over 30, and I think since it's down to 24 now.
Uh-huh. Okay, Bob, thank you so much for helping me.
Okay, well, nice to hear from you. Thanks for coming in. Okay, let's see here. Okay, John, can you hear me?
Yes, sir. Can you hear me?
Yes. How are you?
Good. How you doing, Doc?
Good, thanks.
Good. Just a stupid question. I don't know if you saw my initial email or whatever, but I do have or had a meniscus tear about 5 years ago, and we did orthopedics surgery on it, and it was okay in the result, but not really the best. And I think I may have torn it again in the last couple of weeks. What's kind of the recommendation, or what would be the normal process on that?
Well, so if it's all coming from a re-tear from the meniscus, oftentimes, I mean, we're treating that these days with just a platelet procedure and getting great outcomes. If you've had surgery already for a meniscus, oftentimes that means that they're removing tissue from the joint. And the research is showing that oftentimes after that procedure, people are left with arthritis. So,
yeah, he said that I do have some of that as well.
Okay. I mean, depending on the severity of it, if it's in the mild to moderate range, I would platelets. But if it's beyond that, then it's proven that the arthritis is a significant contributor to the pain issue, then we'd probably recommend the stem cell.
Yeah, I would say it's probably in the mild to moderate arthritis. He didn't say it was significant, but that was back then, I guess.
Okay, good. Well, that's good news.
So yeah,
yeah,
still hurts.
Still hurts, yeah. So typically what we do is, if you come in for an evaluation, we'd look at it with the ultrasound, and with the ultrasound we can see the tears and verify if that's truly where it's coming from.
Okay, so yeah, I got an appointment on Tuesday with you. So.
Oh, fantastic. Well, good. I look forward to seeing you then.
Okay, you bet.
Okay. Any other questions?
Nah, probably think about it more and come talk to you on Tuesday and see how it goes. So.
Okay, sounds good. Well, I'll talk to you then.
All right, thank you, Doc. You bet.
All right, bye-bye. Okay, let's see here. Shelly, can you hear me? Shelly, can you hear me?
Yes, I'm here. Can you hear me?
I can hear you, yes. Hi, how are you?
I'm good. So a friend of mine came in years back and had her ankle done. And I drove her there. And so I knew about you guys. And I had also looked into it in Colorado many years ago when they first started. So I have both knees medially quite degenerated. And I was told to have surgery, 10 years ago on my right knee, and then 2 years ago on both knees. And I'm real close to doing something because I can't live like this anymore. Though I did do a major diet change and my inflammation is way down, for everybody to know that.
Fantastic.
Normally when you have this bad arthritis, would you do the platelet, or would you think, or you still don't know unless I come in and you look at it? But I mean, normally do you just do the platelet lysate, or do you do stem cell on top of that?
Well, I mean, if it's determined that it's moderate to severe, I mean, we're finding that the platelet probably, it's not going to be strong enough to give you a long-term outcome. I mean,
Okay.
we've done folks with moderate to severe arthritis with platelets, and yeah, there's some who've gotten a year's worth of pretty good relief from that.
Yeah.
We're finding that we can get 7+ years of relief with the stem cell. So more times than not, we're recommending the stem cell just because it's a better option for that scenario.
Okay. And then also, I remember when she had her ankle done, that you didn't want her to exercise. Is this common with the knee also, that you don't want the person to exercise too much after the procedure?
Well, so the only limitations that we put on folks is, you know, the first 3-4 days, maybe up to a week, things can get flared up. You know, that's just the nature of you know, what these cells are doing is creating an acute flare up, simply because that is the foundation of healing. And the only restrictions we put on folks is during that time. You know, during that flare up, it's suggested that you take it easy and just get through the flare up. But once that kind of resolves or goes back down to baseline, we highly recommend that you get back to movement as tolerated. And again, we really emphasize the importance of just the rehab and the stabilization process, particularly afterwards, because that will really optimize how one responds to the procedure.
Okay. All right. Well, thank you very much. I'll be making an appointment.
Okay. Well, I look forward to seeing you. Take care. All right. Let's see here. We can try Kirsten again. Dan, do you have her written? Oh, Kirsten, can you hear me now?
Can you hear me?
Oh, yay.
Can you hear me?
Yes, we can hear you.
Yay.
Thanks for being persistent.
Good. You're welcome. What is your success rate?
Well, you know, there's various factors that you know, basically dictate success. And, you know, this is all part of the initial evaluation is, you know, we try and assess that individual and give them a prognosis. So success rate will depend on, you know, I always go through the process of the most important things that will dictate success are how well that individual is taking care of themselves. So, you know, if they're exercising consistently and they have a good low inflammatory diet, then, you know, those are probably the two biggest foundations for optimizing outcome to this. And then from there, we go through a medication review, because there are certain medications, as the previous caller alluded to, that can negatively impact the healing process. And so, you know, if we can make those changes, that will increase outcome. And then we always get an MRI, and particularly anybody who's considering stem cell, we always consider getting an MRI as a first step, because that will give us more information in order to give you a prognosis. But I mean, to put that all together, what that means is, you know, a good candidate has an 80% chance of excellent success of addressing the issue. And that percentage may go down depending on, you know, if those various factors aren't fulfilled.
Okay, well, my next question is, would I be a candidate because I have sciatica on both sides and disc disease, degenerative disc disease, and I am a patient of yours, and Dr. Glaze has given me the steroid injections.
And what type of outcomes has there been with the steroid?
It gives me relief. It calms down the inflammation, and so I do have some success rate, but it always seems to come back to the basics: the hurt, the pain, the immobility.
I see. Okay. Well, you know, a lot of it depends on, and I'm not recalling specifics in your case, but a lot of it depends on, you know, if there's significant narrowing to the neuroforamina, or if it's just simply more of an inflammatory process. You know, if there's significant narrowing and there's a lot of bone spurs and what have you that's causing that narrowing, then the outcome may not be as good as, say, if there's a disc issue contributing to that.
Okay,
So it really kind of depends on the situation itself.
okay. So you would suggest getting an MRI first?
Yeah. Or, if you've had injections, so we have an MRI in you already, so we might be able to provide further prognosis based on.
I see.
How old is that study that was done prior?
Pardon me?
Do you recall how long ago you had an MRI before?
It's probably been about 3.5 years.
Okay. I mean, that might be enough to give us the information we need. But if not, we can, determine whether or not we need to upgrade the MRI.
Okay. And what would you suggest on that? Stem cell or the plasma?
So most of our spine procedures, 99% of our spine procedures are platelet.
Oh, platelet, sorry.
Yeah. And again, the platelet seems to be very, very effective at addressing the vast majority of spine issues.
Okay.
I'm just going to jump in here for a minute, Kristen, because on the pricing, I didn't address spine, and spine is far more complicated with far more injections than if treating a knee or shoulder. So the pricing on spine is going to vary depending on what the treatment plan is. I can tell you that it ranges maybe from $2,500 to $4,000. But so just to be aware of that.
Okay, thank you.
Okay, you're welcome.
Okay, thanks. Okay,
Okay.
I'll have to do it.
Sorry? Okay. Well, moving right along. Hope that addresses your questions, Kirsten, and hope to see you soon. Let's see. Chris, can you hear me?
Yeah, I can hear you.
How are you?
I'm good, thanks.
Good.
I have 3 questions.
Sure.
The first one is, you mentioned interventional orthopedics. What kind of interventional orthopedics?
Well, so all I mean by that is it's just a field of medicine that incorporates physicians like myself who are able to do these procedures using guidance, whether it be an X-ray machine or an ultrasound machine to help guide the needle and the cells specifically to the injured tissue.
Okay, so it's not any mechanical bracing or anything like that?
No, it just strictly applies to the procedure itself and how it's done.
Okay, got it. And then you said that there's rehab after the injections. What kind of rehab are we talking about?
Well, so typically it involves working with a physical therapist and who can guide you. I mean, a lot of times if one's been unsuccessful with treatment, they haven't received the full gamut of rehab simply because they're having too much pain. Pain can limit how far you can get with the rehab process. So, presumably once the procedure is done, regenerative medicine procedure is done, the pain is far, much better. In which case, there's the next step of completing that rehab process. So again, it's usually working with a physical therapy, working on exercises that can correct mechanics and stabilization of the joint and or spine.
And then you mentioned an MRI. Is that covered under the evaluation process, or is that covered under procedures as far as cost?
So as far as cost goes, insurance will cover, the only thing insurance won't cover is the procedure itself, but insurance will cover MRIs. They will cover physical therapy. They'll cover bracing if it's needed. The only thing they won't cover is again, the cell injection.
Okay. So they will cover the MRI and the physical therapy?
Correct.
Okay. Cool. And then, this is all new to me. The only reason I know about it is because I have a girlfriend who's a patient of yours, and she told me about you and about how to get a hold of you regarding this webinar.
Uh-huh.
And so I am missing quite a bit of cartilage in my knees, and only one knee gives me a lot of problem. And how would these injections rebuild the cartilage in my knees?
Well, that's a very good question. And there seems to be a few things that are occurring. The stem cell and platelet, for that matter, the first thing that happens with that is they release a protein that basically mops up chronic inflammation. Okay, and what that does is once that chronic inflammation is mopped up, that goes a long ways in terms of addressing the issues of pain. But equally as important, what it does is it reboots that tissue's ability to heal itself. I mean, understand that all tissues, once injured, they have this innate ability to heal themselves, but that will be blocked if there's chronic inflammation within the tissue. So once that's mopped up, that healing process is rebooted. So that's one mechanism. A second mechanism is if we place a stem cell in, say, a cartilage bed, that stem cell can directly differentiate and turn into a cartilage cell. So that's route number two. And then finally, the stem cells, what they do is they change the physiology and they bring in all these various other players that are involved with the healing process and get that healing, up and going. And over the course of time, that process will layer down more and more tissue. So there's a few things that are in play.
Okay. And then so the PT is to help your body heal and keep that tissue rebuilding as you move forward. Is that correct? Without injury, and it teaches you how to use your body correctly so that you don't re-injure. Is that correct?
Yes, I mean that's one of the goals. Another one is, if you've been dealing with joint pain for a while, that pain has a way of shutting down the muscle support around it.
Mm-hmm.
So, not only do people typically suffer from the arthritic pain itself, but they lack support from all the tissue around it.
Mm-hmm.
It's important to rebuild that tissue that, basically unloads the joint, that supports it better so that you're not loading up that arthritic joint as much.
Mm-hmm.
And again, it's all kind of involved with joint health. And the more things you can do to optimize that joint health, the better you're going to do.
Would this also be useful for rebuilding like a patella tendon?
Yes. Yeah. We've worked on patella tendons, quadricep tendons, rotator cuff tendons. Yeah. I mean, we're finding especially our platelet product is very, very effective at addressing tendon issues.
Cool. Thank you so much. I appreciate your time.
You're so welcome. Thanks for the questions. All right, let's see what else we have down here. Colleen, can you hear me? Can you hear me, Colleen?
Now can you hear me?
Oh, there you are. Yes. Hi, how are you?
Hi, I'm good. A lot of the questions that people pose have helped me a lot to understand quite a bit. I'm now doing some rehab with Mountain View PT, actually by Zoom. And what I have as an issue that's been ongoing is a hip and a back issue, and I can't tell which is where it's really coming from. So what I really need is a good evaluation. So I know that's where I need to start. And so I am going to come in and get a good evaluation from you guys. And
yeah, no, great. I mean, oftentimes the two, back can be confused with hip and vice versa. Hip can be.
Yeah. I can't tell, it's really odd.
Yeah, no.
I've been a long distance runner for years. I'm 81 and I don't run anymore because of this. And so I want to increase my mobility very, very much.
Yeah, no, absolutely. And I mean, the specific diagnosis obviously very critical. I can't tell you the number of times I've seen people who got hip replacement when in fact they had a back issue. So
Yeah.
this is critical.
Yeah. So you've been very helpful. Everybody else has been helpful because you guys already posed some questions that I wanted to ask and they've already been answered. So I can get off now, but I am going to go ahead and make an appointment and come on in
Okay.
and meet somebody there. Yeah.
Well, fantastic. I look forward to seeing you.
Yeah. Thank you.
Take care.
Yeah.
Okay. Irene, can you hear me? Hi, Irene, can you hear me? Let me try that again.
Okay, can you hear me?
Oh, there you are. Yes. Hi, how are you?
I'm good. I have my husband here listening with me, and he has a question.
Oh, okay.
Doc, I'm I'm 71 years old, in really good shape for my age. I'm active in sports. I am battling stage 4 kidney cancer, but that's been ongoing for about 13 years. And different medications. And I've got some metastatic situations developed in the bronchia and also in the bone in the back. But my concern is my right knee. I had a meniscus repair probably 25 years ago. I tore it twice and they removed some meniscus. And I have a little bit of pain walking about, but if I pound or hike in the mountains or stuff, it begins to aggravate me. But 2 questions, is that something we could come in and evaluate? And then really back to the first one was being that I have cancer. Is there any problem with dealing with the blood and platelets, et cetera?
Yeah, so first question, I mean, knees are probably the most common thing we treat. And that's, a very common problem, knee pain with hiking, especially going up and down hills or even stairs for that matter. So by all means, I mean, we that's probably the most common thing we treat. Now, as far as the cancer, I mean, the only thing that I could see as something that may counter affect the procedure is if there's certain medications that can, there's a lot of different medications that can impair that healing process. And so we would just have to review your medicines just to see if there's anything on there. I mean, as far as the platelets themselves go, no, I mean, the platelets are still, they're active. They're doing what they got to do to heal, and the cancer process doesn't impair that unless of course it's cancer of the bone marrow or something like that.
Mm-hmm. Okay, thank you. My wife may have a question for you.
Good. I'm good.
Sure.
Oh, my wife said she's good. So we'll probably make an appointment to come in and see you.
Well, fantastic. I look forward to meeting you.
Thank you.
All right. Take care. Okay, let's see here. Cynthia, can you hear me?
Yes.
How are you? Oh, I may have unmuted you. Can you hear me now?
Okay. Can you hear me?
There we go. Yes. Sorry about that.
All right. Anyway, I'm the one with the son with the autoimmune ankylosing spondylitis.
Oh, okay.
Okay, so I have a few questions before I drag him into another evaluation, because he got diagnosed when he was 18, so he's 27 now. So we've been dealing it for a long time.
Uh-huh.
I know that it's not. You don't have any actual research that says that it can reverse the immune thing condition, but I question whether or not if you're going to use his own bone marrow, will that regenerate the same genetic code that caused his condition in the first place?
No, it wouldn't have any impact on genetics by any means.
Really? Because I mean, isn't the stem cell just rebuilding the blood and the bones with the same genetic code? Because I know it's some sort of, he has a certain code thing that makes it, that causes him to have this. It's like a genetic disease condition.
Right. Yeah. The immune system's gone a little haywire and it's attacking certain parts of the body.
Yeah, and it's started in his hip and his back. So it had a little bit in his shoulders. I mean, it's been, he's actually taking Embro, which, believe it or not, has stalled the progression of it.
Oh, okay.
He was taking statins. He was like, it was just in 6 months, it generated to another part of his joints. So, I mean.
Fantastic. So it stabilized it a bit, it sounds like.
It stabilized it. And so, but, I mean, Embro has its side effects. So,
right.
Well,
so, again, typically when we're dealing with back issues, platelets tends to be strong enough. And yeah, I mean, I would never lead you down the path that this could cure an autoimmune disease. But what we're finding is that it is very powerful at calming down an inflammation and can be very effective at addressing pain issues. We've worked with, a handful of folks with rheumatoid arthritis, and they've done really well, and they've been able to get off certain medications. I mean, again, it's not the cure.
He's not taking, the only thing he has taking for it is the Embro.
Oh, fantastic. Okay.
And, and it's just, he keeps himself, active. I've even got him to try a little bit of yoga and stuff like that to try to kind of keep it loose. But, it doesn't seem like it's going to do anything more. I mean, I'm looking for a way in which it can sort of reverse itself. So he wanted to spend the next, the rest of his life dealing with it if he can.
Well,
there's no research that says otherwise, right?
Yeah. I mean, so it would strictly calm down the inflammation. I mean, the thing with ankylosing spondylitis is a lot of times you get these very large bone spurs that, ultimately end up fusing the spine.
Right. That's
what
I heard. So.
Yeah. I mean, it won't get rid of those bone spurs, but it can, by addressing some of the ligaments that are involved with the spine, can help restabilize it from the standpoint, so it can help stabilize those bone spurs, prevent them from progressing further. And again, can help with just some of the inflammatory issues related to ankle.
Well, the inflammatory issues is not as bad. It's just kind of like the spurs are just kind of hitting and hurting it, He has pain, but it's not nearly as much pain as he did when he was off the Embro.
I see.
So
Okay.
maybe it's not worth it for him. I mean, I have hip issues, so maybe I call him for that. But I mean, it doesn't sound like it's going to be something that's going to be really a big change for him.
I wouldn't say it's going to reverse any of the X-ray findings that you may be seeing.
Yeah. So, I guess that's it. I mean, I talked to him about it, but I don't think he's probably going to want to do it. He's already gone to so many doctors and things like that.
I understand.
And he's 27. It's just kind of a hard road to have to travel all the time. So.
Right. No, of course. I mean, and the bottom line is if he's managing things okay and he's functional and active and doing things he wants to be doing, then stick with what he's doing.
Okay. All right. Well, thank you.
Okay. You bet. Take care. All right. Let's see. Now, so Tisha, apparently we can't unmute you because of the technology on your device. So if you want to just text us your question, we can address it that way. Let's see. Now that's all the hands I'm seeing. So if there's any other questions, go ahead and throw up your hand. Or Dana, if you have some written questions that you want to just give to me and I can answer them that way.
Can you hear me?
It looks like I just unmuted you, Robert. Robert Goslin is
Okay.
back on.
You mentioned a low inflammatory diet. Can you tell a few words about that?
Yeah, sure. At essence, what we're finding, as you know well, that the more we can eliminate processed foods and sugars, that's gonna be very, very powerful in terms of minimizing systemic inflammation. And anytime we can do that, we're going to help minimize localized inflammation, arthritic pain, that type of thing. And that in and of itself can help with the healing process as well. So, those are some of the basics. There's been a lot of interesting research on intermittent fasting as lowering systemic inflammation. There's a variety of different methods out there, but I try and keep it at its most simple and basic, which is just trying to minimize sugars and processed food.
Okay, well, that's a lot of the food that we eat normally. So thank you.
Okay. All right. Anything else?
No.
Okay. Thank you, Robert. Appreciate it. Let's see. Shelley, did you have another question?
I just wanted to add a little bit with what I've experienced in the last 6 weeks of non-inflammatory foods. Sugar's a big one.
Yeah.
Wheat and corn have, this is something I've never done this. I've dabbled with, Xing out certain things, but I've never done it this strictly before. And I have to say that my inflammation in my knees is down probably 90%. So I really feel that I hope in the future the medical world will address diet more vigorously, because I really feel it makes a difference. And nut butters, no wheat, no corn, sugar, way down on the sugar, because I was kind of a sugar freak like most of Americans are.
Guilty.
So anyway, I just wanted to add that, and I really appreciate your information, and also, so I had X-rays and MRIs in the last month, so that would be good, right? That's fine.
Perfect.
Okay.
That'll help expedite the process for sure.
Yeah. Okay. Thank you so much.
Well, thanks for sharing that. I appreciate that.
No problem.
The diet is so powerful. And I can't tell you all how many times I've heard that from so many different patients. They make a change in their diet and they're doing so much better. So very powerful. Again, not only at addressing symptoms, but really critical in terms of optimizing your own body's potential for healing. So again, anybody who's considering this technology, we always emphasize the importance of a clean diet, in combination with exercise. Again, probably the two most important things you can do to help optimize outcome. So, okay, well, we're dwindling down here. Trisha, again, I'm sorry. I think it's the technology is not allowing us to contact with you. And that's all the hands I'm seeing.
It looks like Kristen Dyer has her hand back up.
Oh, there we go. Thank you. Kristen, can you hear me? Let's try that again. Sorry, Kristen, but I think this one took a while last time, so maybe we'll just be patient. Well, we'll give that a moment, and hopefully things come through.
I'll just say, excuse me, Kristen and Tisha, if you do want to write out your answer, I can read it out to the doctor, since we can't seem to unmute you right now. Do
you have any other written questions that that were texted, Dana?
Well, there were a number that were texted, and I think they were all answered. I mean, I've answered them online, and you've answered them live.
Okay, great, great. And Kirsten and Trisha, I mean, you can always, certainly email us or give us a call. We can certainly try and address your questions that way too. Sorry, I guess there's no perfect technology, right? Let me try it one more time. Yeah.
I will add one other thing. There was a question. I'm not sure if Robin is still on the call. Yes, she is. She was asking about bunions, and you might want to speak to that.
Oh, sure. So bunions, we're finding that bunions are in large part due to ligament laxity. There are little tiny collateral ligaments on the side of your toe there that get stretched out over time, often due to footwear. And over the course of time, as that gets more and more stretched out, that can cause more stress and strain to the cartilage, contributing to arthritis. And then, ultimately leads to the deformity and bone spur. So, what we'll do with that, and we treated a number of these, is we'll spend quite a bit of time on injecting the ligament, because we can, oftentimes tighten that ligament back up by injecting it with platelets. And that too, that in of itself can reduce the deformity itself. But we also put platelets in the joint as well, and find that very effective in terms of, addressing that chronic inflammation in the joint, and getting that healing potential up and going again. So, we tend to find that pretty effective treatment for that. Hope that answers your question.
Yes, it does. I just, somebody just told me they were bunions. I'm not convinced that they are, but it's just that swollen joint there at the ball of the foot. So, and I have had plantar fasciitis before, and I did have a bone spur with that, but I've since cured that, but in the bunions, and I'm wondering too, if I just reduce wheat, whether the inflammation will just come down from that. I mean, eliminate wheat, and before I try something like the platelets, but at least I could start there and then maybe move to the platelet treatment.
Absolutely. I mean, again, I always stress, you always start with the basics, diet, make the dietary changes, that in combination with just, learning how to strengthen and stabilize the foot. Sometimes that's all you need. For some reason you go through that process and it doesn't help, then we consider other injections like this. But by all means, I mean, the diet is very powerful. Exercises are very powerful.
So, I'm wondering, I tore my meniscus a year ago, and it's all but healed. If I'm driving and I've got my foot kind of resting outward, when I'm at my destination, I end up getting out of the car and having to limp because it just, didn't like that. So, But I would like to go skiing and so forth. So I'm wondering if a platelet injection, with that, and then the two bunions on each foot, sort of like a package, is going to run about, I guess, about $1,600, something like that, or
something in that neighborhood. Yes. That sounds about right. And I mean, boy, we've really we've treated a number of skiers who've had meniscal issues, and they're back up and skiing and doing great. So actually, it's great because I'm always reminded every year. I get a postcard from one of my patients who, he's in Mammoth one year and then someplace else, somewhere else. So it's always fun to hear from him and see how well he's doing. So.
Okay, well, thank you.
You're so welcome. Okay, well, Was Trisha able to text something in, or?
Yeah, she did. She says she has osteoarthritis in her hips. She was a professional ballet dancer and now a Pilates instructor. She has an MRI, doing a great diet, and wants to know if she's a candidate.
You know, I would say absolutely. I mean, it sounds like you're active. It sounds like you have a good diet. Again, those are really the foundation of the healing process. And yeah, we just need to take a look at your films, examine you. You know, given that you're so active, it sounds like you probably have maintained your range of motion, which I find, particularly in regards to hips, that would help optimize response to this. You know, that final piece of the puzzle would just be, you know, the severity of arthritis to the hip. I mean, I do always let people know that hips they're not necessarily our best responders. But as I say, I mean, if people are taking care of themselves and they've maintained their range of motion, they're going to do a lot better than you know, who isn't doing that work. We treat quite a bit of hips. Did that address all the facets of the question, Dana? I'm not sure if I remembered all the details.
It did, and unfortunately, she said because of the COVID protocol, she can't come in right now, and is wondering if you would just take a look at her MRI.
Sure, if you want to send it up. You know, sometimes we even do phone consultations, you know, and after reviewing the MRI. So, I mean, there's other ways we can make an assessment. Okay. Well, any other text questions, Dana?
No, Tisha just responded. She said that would be good in Grass Valley. And yes, we are in Grass Valley. And as Doctor said, we can also set up a phone consultation.
Yeah. Okay. Well, good. Well, for all of you who've stuck with us, thanks for attending, and thanks for tuning in on Zoom tonight to listen to our webinar. And again, the contact information is still on the screen. Please write it down. If you have any other questions, don't hesitate to contact us. Or again, if you want to see if you're a candidate for this treatment, please come and see us, and we'd be happy to see you and to assess things. Any other notes from your end, Dana?
Nope, we're all set here. Thank you.
Okay, thanks everybody. Take care.